So welcome everyone to today's endocrinology grand rounds, and we are very happy to have today Dr. David Armstrong from the rheumatology division to talk to us. Dr. Armstrong is currently an assistant professor in the Division of Rheumatology in the Department of Medicine here. He's been here for the last since 2022. He graduated DO from Lake Erie College of Osteopathic Medicine. Subsequently, he did his residency at the Eisenhower Army Medical Center and did fellowship in rheumatology at Walter Reed Army Medical Center in DC. He spent another 6 or 7 years teaching at the university, Uniform Services University Medical Center, and has been very active in teaching, developing several courses for medical students and for residents, which he has continued to do here. And we have had the pleasure of interacting with him because he shares the space with us at the VA. And the endocrine and rheumatology clinics are in the same space. He has been an excellent mentor for several students, and many of our residents actually took up rheumatology because of him, I think, because he has inspired them with, because our rheumatology program did not have a fellowship for a couple of decades, I think now. And he came in and restarted the rheumatology fellowship program. So today he's going to talk about this because we had been, when interacting with him, talking about the common things that we have in terms of autoimmunity, inflammation, and many of the vague symptoms that people present with both in rheumatology and endocrinology. We are sent people who have weird symptoms. So it'll be very nice for us to listen to his topic of RheumEndocrinology. Thank you. Thank you.
Well, thanks so much, Dr. Mock, for that warm introduction. I appreciate it. Makes all my small accomplishments seem gigantic, but happy to be here, and we'll kind of talk about overlap stuff today, some learning and education stuff, which I've come across too, because that's really my passion is in education and teaching next generation, because I can't work forever. So I haven't run a tally count, but I think we're moving close to 6 at least residents have graduated going into rheumatology, which is great. So, and we have opened, if we have empty slots for the fellows, we have opened rotations as a fellow in rheumatology if you are so interested. We have 2 critical care fellows who've rotated with us and really enjoyed it. So that's an opportunity. We give, first preference to internal medicine, but if you're interested in rheumatology, we love having fellows because you guys are also smart. So it's great. And differential diagnosis is huge. But really, I called this talk today RheumEndocrinology. We'll talk about some overlap. And then at the end, I got some great cases for you all. So be excited. So I have no disclosures, but I do, as a employed by the Department of Veteran Affairs, have to give you my caveat that nothing represents the VA in our talk today. And we'll have lots of humor, so that's good. So learning objectives, we'll talk about some overlap disease manifestations. In my perspective on those as a rheumatologist, in working with you all in endocrinology. We'll talk a little bit about corticosteroids, complications, and osteoporosis management. We'll also review musculoskeletal complications of diabetes, and then we'll have some fun images and cases that relate to both specialties. So I like to say no puns, but Will Ferrell's like pun intended. So we'll start with dessert first. So no diabetes jokes, but yeah, diabetes jokes. Anyone in the chat or the group with questions or interesting cases that you want to talk about that we may or may not highlight during the talk today? Yeah, we'll
talk all the time.
We can save questions at the end, and let me see here if there's anybody in the chat showed up in the taskbar.
Asking for things that you're not gonna.
Or that I may talk about. Yeah. I mean, I'll talk on end about interesting stuff that I found, like how statins affect testosterone production, what have you. Happy to talk about anything you guys want to talk about first. You seem like you had a question, sir. Oh, that's okay.
I'm interested in thinking about rheumatology and
Sure. And we will highlight some of that today, particularly with our new medications and decline of use of corticosteroids. So we'll talk about that slightly. And I don't see, a lot of adrenal insufficiency anymore with our usage of steroids and new protocols. And then we'll talk a little bit about Acthar gel, which is, kind of our new, sorry, Cosentropin gel. Not supposed to use brand names here, as well. So,
what about not after intervention, but before it? Autoimmunity like lupus.
Related to the adrenal, I don't have a lot of data on that. Usually, unfortunately, this is our catchment is we usually, unfortunately, find disease that's advanced. If we're finding early disease, that's great. But I don't have a lot of data and study on pre-diagnosis effect on the adrenal glands and steroids. But, from what I would imagine, because of the immune response revved up, but I don't think anyone right now, at least in rheumatology, is studying that. But great question. I only have after the fact, after we start doing damage and using medications. Yeah, great question. How do I get off the pointer, Kelly? I was just going to look at the here. Oh, I just wanted to see if I could look at the
chat.
chat. See if
Okay,
anybody had
so
a question.
chat bar,
Oh, that's right.
and then we'll hit that. I looked, I didn't see anything over here. Chat.
Yeah. No.
Yeah, no,
Okay.
yeah, and then just hit that.
Gotcha. All right.
Okay.
So, as I started, teaching, quite more in depth, especially with the fellowship program, this was a great, find in one of my podcasts is, as we teach and as fellows teach as well, really making, the connection formative rather than informative. I can sit here and talk to you all day, but until we make web associated connections with the formative learning, understand the pathophysiology, and encompass that, we're really not teaching. I'm just telling. And especially with AI now, you can look up anything on Google, but is it accurate? And I found a lot of inaccuracies even with the research for this presentation. But how do we integrate that to make it interesting for the learner and interactive? The more that you do that, the better. And this is another interesting thing from the same podcast. They talk about, facilitating long-term knowledge and retention. And actually physically writing it down on a piece of paper will facilitate better long-term retention of skills. You can look it up, keep it on your phone, take notes. It doesn't work. They recommend having a journal or a commonplace book to carry with you to write down interesting facts like for lecture today, but that will help you retain it long-term. And, this is a good one from one of my favorite rheumatologists locally at UK who's since passed on, Dr. Lightfoot. Especially with medical education, national football players, they don't make mistakes. College players make mistakes, and that's what makes it interesting and entertaining, right? So that's what I enjoy about education, right? Is finding those mistakes, correcting them, and then making that a formative learning experience. And however you do that, that's going to make learners have the joy of learning. They smile, they want to have the answer, they want to be interactive with you. So try to incorporate some of those skills into your teaching. And I found that's the most joy that I get. And why do we highlight this? So this came up recently, the 150th year, I think, or so, of the forgetting curve. So everything I tell you today, 10% you're going to remember in a week, right? But if you write it down, make a connection in your mind, you're going to remember that forever. And they've studied this, with kids and, algebra problems. If you have positive reinforcement, you're doing great, got the question right. The retention is zero. But if you give a safe negative reinforcement, that's not great. This is how we do it. This is how we do these problems and make it interactive. The retention is almost lifelong. So it's impressive. So try not to forget the key points. I'll bring them up again. So repetition, as we say, is the key to adult learning. So we'll talk first about overlap disease that affect all of us. I like Dr. Cave's quote, everybody in the autoimmune liver disease clinic has a rheumatic diagnosis, which is kind of true. And then really, as I teach today, the Abraham Kaplan, as a scientist solves problems, he tells you how to solve them in a way that he can always solve them best. So in dealing with systemic disease, which is really what I focus on, that's how I solve problems. So that'll be kind of the focus of our talk today. So overlap diseases we'll talk about autoimmune thyroid disease, adrenal gland dysfunction, and corticosteroids. Unfortunately, not before we start steroids. Sarcoidosis, osteoporosis, and then musculoskeletal overlap. So when we talk about Hashimoto's and Graves', we're going to talk about the ANA testing, right? And rheumatologist's favorite subject. We could talk about ANA all day. It even came up at M&M conference today. What do you think about ANA, and should we have tested in the patient with ITP and antiphospholipid antibody positivity? Yes, should have, but there's better tests, right? And then really we'll talk about really the big interplay between Sjogren's, autoimmune liver disease, other autoimmune connective tissue disease related to autoimmune thyroid disease. So lots of acronyms today, so I'll abbreviate a little bit. So ANA testing, right? People test it all the time. Vague and non-specific complaints like fatigue, musculoskeletal complaints, achy, painy, right? And so, in testing, large cohort study, 1.5 million patients, guess what? A lot of them had positive ANA tests. And a good percentage, about a third, had autoimmune thyroid disease. And we'll talk about how that's important a little bit later on. Now, historically, if you use AI, we're talking about using Google Learning and other stuff, it'll tell you that 46% of patients with a positive ANA will have autoimmune thyroid disease, which is what I've quoted to patients for years. I looked up the original study, it was 78 patients and no higher incidence compared to controls with positive ANA testing. So, but better study, lower incidence, and that's really where, if you look at core learning and other stuff, the AI is going to pull up data which may not be accurate. So do the research behind the research and really get accurate data for that. So ANA testing. So my big question is, why are we still testing an ANA, right? So we test an ANA, average 10 to 20% of the general population will have a positive ANA. Doesn't really tell us anything that we want to know. And in talking with one of the hematology fellows today after our conference, about the ANA test, I'm able to give him hard statistics, which are proven in large cohorts, is 1 out of 30 patients referred for ANA clinic, to my clinic is positive. 1 out of 30 will have lupus. So I'm able to make a life-saving intervention. So do I discourage checking ANA? No, but there's better tests to check when you're looking at ANA if you're looking for a specific autoimmune disease. And another Dr. Lightfoot quote. You know what the test result's going to be. It's either positive, negative, or indeterminate. It's what you're going to do with those results, right? So check labs where you have an intent as to what you're going to do. So Hashimoto's, Graves' disease, and Sjogren's. So we no longer call Sjogren's syndrome. It's now a disease, so we call it Sjogren's syndrome. So if you want to speak proper, intelligent about Sjogren's, that's the important thing to do. And when we look at symptoms, right, we talk about oral or ocular dryness, and this is our questionnaire from our classification criteria. We're word snobs in rheumatology. We don't say diagnosis, we say classification. That gives us wiggle room for error and exceptions to the norm. And a lot of times with dry eyes, patients will have watery eyes. So they may not say, my eyes are dry, they're watery, which can be a sign of dryness. So do you feel like you have dry eye symptoms, a sensation of dryness with gravel or sand in the eyes? Are you using over-the-counter tears more than 3 times a day? Have you had a daily feeling of dry mouth for several months? And then do you have to frequently drink to swallow food? So those are important questions, but you can ask dry eyes and dry mouth, and we'll talk about why that may be important in the endocrinology clinic. So again, 30% of patients with autoimmune thyroid disease will have, or 30% of patients with Sjogren's will have autoimmune thyroid disease. So we typically, if not checked, we'll check thyroid testing on an annual basis with our Sjogren's patients because there's a high incidence. So there's also a high incidence of autoimmune liver disease, particularly PBC with Sjogren's syndrome. So they give us a wide range in the literature, 3.5 to 73%. But I hearken back to Dr. Cave's quote, everybody in the autoimmune liver disease clinic has a separate autoimmune disease that you deal with, Dave. And there is some small incidence of autoimmune hepatitis as well in Sjogren's patients. The frequency with these patients who have autoimmune liver disease of having autoimmune thyroid disease, similar percentages, about 30%. So we're seeing a big overlap between these 3 disease processes and 3 different specialties. the big key, which I'll tell you, this is one of the key, facts is early detection is difficult. They're going to have a lot of non-specific symptoms, similar to patients who either have thyroid disease or think they have thyroid disease and do not. They'll have fatigue, itchiness, dry mouth, and dry eyes. So all three disease entities can present very similarly. So is there autoimmune thyroid disease and other diseases I deal with? There sure is. And so really we think 3 times higher risk of hypothyroidism in RA patients. We see a large cohort, 1,500 patients with either Hashimoto's or Graves' disease. And, what are we seeing? A lot of Sjogren's, a lot of mixed connective tissue disease, which can have manifestations of Sjogren's, systemic sclerosis, lupus, or rheumatoid arthritis. So joint pain, photosensitive rashes, Raynaud's, those type of symptoms, and sometimes ILD or more severe complications. Really, significance is that there is autoimmune thyroid disease in all these different diseases, so higher than the general population. And, there's some other literature out there without specific references that, 51% of patients with Hashimoto's and 16% of patients with Graves' disease have a systemic rheumatic disorder, what have you. So really, what's my summary here? So we have a lot of overlap between autoimmune thyroid disease, autoimmune diseases that are rheumatic, and autoimmune liver disease. So what my recommendation would be is corollary is I don't have data from patients that you see in your clinics, and I looked for research to suggest, study of patients with autoimmune thyroid disease, how many have an additional autoimmune disease. So good research project. If anybody's interested, if you have large cohorts, particularly at the VA, that research may be beneficial. So I can only give corollaries as to, I would recommend screening for Sjogren's in your patients with autoimmune thyroid disease, simply asking the questions about dry eyes and dry mouth. If there's a concern, happy to see them. Or, if you know how to do lab tests, checking for Sjogren's, in particular with the Sjogren's syndrome antibody A or B would be helpful. Also, a higher incidence of autoimmune thyroid disease in patients with autoimmune liver disease. So my corollary would be, it'd be helpful when you're looking at a patient with Graves or Hashimoto's, look at the CMP, see if there's elevations in any liver enzymes, ALK phos, bilirubin, which will provide clues for different types of autoimmune liver disease. And what do we do if we're concerned that they might have, another rheumatic disease that I deal with? I came up with a question set, which I think would be helpful. Again, this is 30 seconds additional work with asking a few additional questions and labs review. Do you have rashes, particularly in photosensitive areas and that are scarring, looking for lupus and other disease like mixed connective tissue disease? Do you have joint pain and swelling, particularly in the MCPs? An easy way to do this, if you're concerned that you're not able to check for synovitis, we teach the residents to have the patient hold out their fist. If you can see ridges and valleys, that suggests there's no synovitis in the MCPs. Or if it's straight across like a plateau, that there's inflammation there. The other test that we do is just a handshake, right? How many of you shake hands when you see patients? Anybody? No handshake, not a handshaker, handshaker, right? Fist bumper. That's all right. Right? 2 methods, right? If you do a fist bump, right, you can look at the MCPs. If you do a handshake, a normal handshake grip, and they wince in pain, that suggests there's inflammation in MCPs. So you can do it either way, if you're not a handshaker or a handshaker. That's great. Other things we look for, muscle weakness, right? Not muscle pain. That's more polymodula rheumatica, but if they're having progressive muscle weakness, we're concerned about myositis or other conditions associated with inflammatory muscle disease. New shortness of breath and abnormal chest x-ray. If you are looking at chest x-rays for a variety of reasons, right? If you're seeing interstitial changes and they have a positive ANA or seeing you for autoimmune thyroid disease, there's a concern that they may have myositis or another condition like systemic sclerosis. And then Raynaud's symptoms. We get a lot of questions about Raynaud's. Fingers turn white in the cold. That's pretty normal. But if we get triphasic color changes, right? White to blue to red, that's very suggestive of Raynaud's and not as concerning in a younger patient. Lower risk, especially if they don't have trophic tissue changes, ulcers, digital gangrene. But in a patient who's 50 or 60 with new onset of Raynaud's, very concerning for autoimmune connective tissue disease. So it's when, how, and then different colors. But I would take note of this slide. I think it's helpful, especially with autoimmune thyroid disease patients. They may have another disease, and what do you do about it, and who do you send them to, and how do you evaluate it? But I try to consolidate into 30 seconds so you can add it to your visits. All right. I know you've been waiting for the adrenal gland dysfunction corticosteroids, sir. Sorry, I don't have the precursor to it. So, really, we're just not seeing as much adrenal gland dysfunction and adrenal insufficiency anymore. And the reason is we have better guidelines and better treatments. Even for our more complex diseases like giant cell arteritis, where we used to give steroids for a couple of years, we have new IL-6 inhibitors and other therapies where we really limit the amount of steroids that patients are given. And I just put this on here for reference. This is the last case of adrenal insufficiency that I had was in 2010. So abruptly stopped 1 mg per kg of steroids in someone with IgG4 disease before they got debulking surgery. Fortunately, it was a young service member. I think he was 32 or so, but barely survived debulking surgery. Eventually, the anesthesiologist realized he'd been getting steroids and they were stopped, and they were able to intraoperatively save his life. So, but we don't see that happen much anymore, which is a good thing. And my new favorite phrase for corticosteroids is Satan's little helper. I pulled that from one of my presentations that I was listening to. And so I try to limit the amount of corticosteroids. If patients, really want steroids, I'll give them for 5 days. That way they don't have to taper, and try to limit that course to once a month, and put less stress on the adrenal glands. Our big outliers that we still see are sarcoidosis and lupus, and we'll talk about those a little bit later. Or as I like to joke, it's like giving sugar to kids. It's so addictive to that patient population. It's ridiculous. And if you all weren't aware, that's what they put in kids' meals, especially macaroni and cheese. If you eat out, they put sugar in it. That's why kids love macaroni and cheese, Applebee's, and otherwise. It's an old restaurant secret. That burger is everything loaded with sugar. So, when we talk about, adrenal, dysfunction and risk with steroids, really the only mention in our guidelines is preoperatively, which our recommendation is to continue the current dose of steroids throughout the preoperative and postoperative period. This is applied to knee and hip replacement, but that's kind of our mantra, at least at this point in time, and really don't see any cases of adrenal insufficiency if we do that. Most surgeons are very comfortable with steroids. Although I will tell you the infection risk well proven out to be 2.5-fold increase infection risk preoperatively with operative wound site infection. Comparatively, DMARDs and biologics we use only about 1.5-fold increase risk. So they're much safer, but most surgeons very concerned about Enbrel or methotrexate. They have no idea. No, just give them steroids. They'll be fine. Stop the methotrexate. That might cause an infection, which is not true. So really, the repository corticotropin injection is a great idea for replacement of steroids, inducing adrenal glands to produce natural cortisol. The trouble is it's very expensive, as you can see, $40,000 per vial, right? So great idea. This used to be generic, and of course, a manufacturer came on board and the price increased significantly. Do I use it occasionally for very refractory disease or for patients who have, severe complications with steroids or risk, or have failed other medications, but quite infrequent because of cost. FDA approval only currently for infantile spasms and multiple sclerosis, but we'll talk about other case reports here in a second. And as you can see, we'll look at the regimens for using the corticotropin injection. You can see that cortisol plummets about 24 hours after, but mimics slightly well natural cortisol release. Yes, sir.
Get me in. That was the side effect.
There's some thought that the endogenous causes less side effects, and it more closely mimics natural cortisol release and cycle.
There's some evidence for that.
Basically, the chart that we looked at, and when you look at, giving someone prednisone, I think the half-life is somewhere around 6 to 12 hours. So drops, right? They came out with, well, I can't use brand names, not supposed to use brand names for this presentation, but they did come out with a controlled release prednisone equivalent, and it's given in the evening. It has controlled release, but the trouble is it costs about 500 times as much. Yeah, as prednisone.
About the advantages So, I mean, even without the cost.
Yes.
And to what degree there would be an advantage relative to the cost.
Yes, sir.
So in the past, I mean, this was the theoretical reason as to why.
Gel, right?
What is that for gel? Okay.
I know you won't say the name, but.
You can. That's all right.
So the thing about it, there are two things. One is there is no adrenal suppression. Okay. So in terms of stopping it, you can do better because you're giving ACTH. You're not suppressing the adrenal. But the other theory was that the adrenal, when you give ACTH, it makes other steroids. I mean, when you give prednisone or hydrocortisone, you're doing one steroid.
Yeah.
But the adrenal, the spectrum of steroids released by the adrenal is much wider.
Yeah.
So that maybe these other things have effects which we don't know. So before all these disease modifying agents came up, they were looking for what other ways can we get a better response. And I think these were some things that were tried. And I think since the newer agents have come, nobody really wants and other things that you can go through instead of trying.
Yeah, my fellow who graduated and moved a year ago sent me a message and said a rheumatologist had referred a patient who they had an active gel and they said they don't need steroids, please wean them off. And they didn't know, she didn't know how to do that. And I'm like, I have never seen a patient on this, so
Yes.
I had to read up a little bit.
They list it on a manufacturer PDF as there is some risk, for adrenal insufficiency and just stopping it. Now, they just put there's some risk. Now, if you look at the data, it says there's significant risk and you definitely need a taper. I didn't put it in the presentation because I was looking at it this afternoon. But there is a tapering, like 40 for a couple days, then 30, then 10, and it comes in a multi-dose vial. So theoretically, you should taper it off, and there is some potential risk for adrenal insufficiency. You shouldn't use it if they have adrenal insufficiency already. So there's some caveats to that. But even the dosing, the case reports, is not even how it works physiologically, except for the lupus dosing is daily. We can see it only lasts 24 hours, but giving it twice a week, what does it do twice a week? That doesn't make any sense. Doing it, for a couple weeks at a time and then stopping, we're not seeing chronic use. I did have one lupus patient that I saw in second opinion consultation getting daily injections for several years when it continued, and that's not even how it's been studied. So, which to answer your question, is it necessarily better? No, I think it's a tool and really a tool for short-term use. If somebody's in ICU with other complications, can't give steroids for a variety of reasons, it would have to be an extremely rainy day. They've got disseminated, mycobacterium and other risk factors, then potentially it might be safer than steroids. So, but
Hoping that their adrenals are intact,
yes, if their adrenals are intact.
if the TB didn't get that.
Yes, exactly. Well, atypical atypical, yeah. But it is a great tool, no. But it is a tool. It can be used short term if there's some severe complications to steroids, or if you feel like it may work better and produce the other access, steroids within the adrenal gland itself. But purely a tool. But I mention it because you may get questions, and there is a tapering protocol. I can email that out afterwards to Kelly for you all, so that if the questions comes up again, there's some potential risk to it. But there's some people who are using it. I don't use it regularly, but there's some potential for it. And then it can be compounded too. So I have one patient could not afford it because of the cost, was getting it through a compounded pharmacy, and felt it was working well for her very complex disease. So there's some ability to get it less expensive through compound pharmacy too. All great questions. Any more questions on
So what does AI say?
artificial intelligence?
I don't know.
Yes.
What does AI say about the?
Oh, about it?
Yeah.
Oh, yeah, it's greatest thing ever. Yeah. But no, I only did, I can't think of the term. It's like passkeys or something, but the inputs were, adrenal insufficiency and risk, and, I used the brand name of the drug. And it was like severe, needs a tapering protocol, can definitely induce adrenal insufficiency, but you look at the manufacturer handle, like, it might do it. but I think there's some risk there. But I've never had to taper someone off, but I know now how to, and I'll get you the information how to as well. I know, I know, but it's not factual, you know, or it may be factual and it may be glossed over in actual literature. So, yeah, I like it. You have a commonplace book. It's great. It's great. I love it. So, we look at lupus too. That's our other cohort of, once they're on steroids, that they just cannot get off steroids. It's very difficult. And Michelle Petrie, who is our fairy godmother, I like to joke of all things lupus at Johns Hopkins, great longevity trial in looking at prednisone and steroid usage in lupus patients. And really a lot of benefit actually from just replacing vitamin D. So when we replace vitamin D, lower kidney disease, lower proteinuria, and really decreased risk of thrombotic events. So, it's on our old note from the VA, did you check vitamin D screening? And I was like, all right, and in preparing for this, I'm like, man, I really need to make sure that we do have adequate vitamin D because of all the other benefits of, simply replacing a vitamin for lupus patients. And she has some good quotes here. Say no to just say no to prednisone. The P in prednisone stands for poison. It's great. I like a lot of good quotes here. You can laugh. It's okay. We can have fun. Oh, no, no, just 25.
Well, I read a paper one time that stood in my mind all this time, it was a long time ago, but and the intent of the paper was not to compare the active with the inactive. It was some other purpose, but what they found is that Black people had a lower vitamin D. We know that, but their active vitamin D was the same. And that stood in my mind all these years. So I always wonder when people are talking about vitamin.
Yes, which is better. I will have to get back on that, but I will add it to the cosyntropin tapering too. That's evidence on that. And it's a good lead in. We'll talk about a little bit about the 125 with sarcoidosis too. It's like you've been in the crowd and read my lecture already, so it's great. Love it. And look at Michelle Petrie's data with risk for prednisone, 50% increased risk at doses of 6 milligrams or above. Mostly fractures and cataracts are the big risk factors. 18 milligrams per day, 2.5-fold increase, which is no surprise. Higher steroids, more risk, right? So, really when we talk about, less use of corticosteroids, is better, right? That's everyone knows that now. We have recommendations to suggest that they should continue oral steroids throughout the preoperative and postoperative period, even though we know that there's an increased risk of surgical site infection, lowering adrenal insufficiency and crisis. The repository cosyntropin injection, somewhat controversial, may have some benefit with endogenous cortisol release if used appropriately, which is probably daily, and then does probably require tapering for safety. Vitamin D, essential to lupus patients, and prednisone is bad. So sarcoidosis. So this is great. This was earth-shattering that came out this year, right? If I could, have a nickel for every sarcoidosis patient that I've seen that will not get off of steroids, I'd probably have $100,000 in the bank. So they just love steroids, as do lupus patients. They feel better on them. But our first line recommendations now is to start methotrexate. Start a DMARD, don't even start steroids. So we're not even going down that route, which is awesome. And so I sent that out to pulmonary critical care folks as soon as it came out, and Dr. Bobby was super excited. He's like, I'm never using steroids again. I can't get people off of steroids. But then we can use a TNF inhibitor. Yeah, so I do get those referrals really from medication management, and usually it's infliximab is our drug of choice for neurosarcoidosis, and it's more management. But we do have other treatments, so which is great. DMARD's not quite as successful for that, but TNFs, as long as there's no contraindications, work fairly well. But I did put this in for you guys. Don't know if it comes up on your boards with how vitamin D changes and is hydroxylated with sarcoidosis, but both from the inflammation and inflammatory pathways, we see the conversion and, of course, the hypercalcemia associated with that. Everybody good on committing that one to memory? So this has been a big push, and I'm not sure really why. About 10 to 15% of my board certification questions now are on osteoporosis, and we really have no guidelines. You know, this comes up a lot when we get folks that are referred for second line agents to my clinic, and I'm like, don't really do that. I don't have privileging at the VA. That's not something I usually do. You know, for the most part in my career, osteoporosis has remained within endocrinology, and I will start a bisphosphonate or other first line therapy if I'm starting high dose steroids with risk. But it's become a thing, and that may be regionally in some parts of the US where, you know, I can't imagine there's a part of the US where there's less rheumatologists than there are endocrinologists, but they may exist. So, but I appreciate all the hard work you guys do in managing osteoporosis. We do have guidelines really for exactly the same situation we talked about, which is, you know, I'm starting steroids and there's risk to bone density. So I'm going to start a bisphosphonate. And they deviate a little bit. You know, we have the low, moderate, high risk of fracture. And then they have a very high risk category that also includes the dosing of steroids, which the equivalent, I did the math on this, you know, 5 grams per year equilibrates to about 13 milligrams of prednisone per day. So if they're getting 13 or higher, they're very high risk, need to be on a bisphosphonate. But I don't think it's rocket science or any change to your guys' guidelines. But really, that's the only criteria we have. And what frustrates me about the board questions is they all have an endocrinology reference. So I'm not sure what that big pendulum shift is for, but it's out there. So.
How many of the individuals with rheumatologic disorders getting more than 30 are getting the prevention?
Usually we're not trying to keep them there long. So, you know, I would say, you know, there's nobody that I have in my clinic that's on long-term high-dose steroids. You know, I have some outliers, people that just refuse to do anything but steroids. And my classic example, I took care of a pharmacist, and he had been on 20 milligrams of prednisone for 25 years for rheumatoid arthritis. I saw him, I said, sir, we have much better medications. He's like, don't give me methotrexate, it's poison. Right? We know that prednisone is poison. And I said, this is poisoning you, sir. He's like, no, I trust it, it works. And this is a pharmacist. I said, what about your skin thinning, your diabetes, the cataracts, your heart attack, your osteoporosis, all related? Nope, I won't take methotrexate. So we have some folks that are given steroids, don't want to do anything else, don't believe that there's lower risk. Yes, I was getting there. I just wanted to give you a colorful example of who. So typically, if they're going to be in high dose for separate diagnosis, let's say GPA or granulomatous polyangiitis, you know, we don't use the old term anymore because of the association. Giant cell arteritis without ability to get a second line agent, you know, I will do a baseline DEXA and put them on medium dose bisphosphonate for prophylaxis. So we know that that's a set point. Then we get some outliers that want to be on steroids, don't trust any other medications, you know, have a normal baseline bone density. I have one gentleman right now with rheumatoid arthritis, you know, he's taking methotrexate, but I cannot wean him off of prednisone. He wants to take 20 milligrams a day. Has a normal baseline bone density, doesn't want to take any more medications. So we're stuck with patient choice where, you know, I think it's the big dichotomy of if the bone density is normal, you know, I'm telling there's potential risk. Most want to wait and see before adding an additional medication. And that's already, you've self-selected for someone who just doesn't trust medications that have other risk. You know, other folks, you know, especially with high dose for 3 to 6 months, you know, much more willing because of the severity of their diagnosis to start a bisphosphonate. So it's a discussion we have. And I would say the other cohort who doesn't trust anything is very difficult. I do my best and I know they should be on one, but I can't salesmanship it. The others who are on short term, you know, I would say at least 75%.
Moderate dose, right? So you were talking about like 35 milligrams of phosphonate. 70 or a daily dose?
35, yeah, if they have normal bone density at baseline. So
that's the whole thing, right? With GIO, particularly osteoporosis, most of them, the DEXA is normal, but you base it on the period, like the amount of steroids and how long it's going to take.
yes,
Like before with a lung transplant, they were on steroids for a very long time. Like we know now, most of them have gone into steroid sparing regimen, perhaps lung and heart a little longer. But so most of them don't need that. But then they're on, the dose you have there, which is like the most important thing.
Yeah, so
Then-
30 for 30 days
Yeah.
or more
Yeah.
at baseline. So they probably should be on one. How long to continue that? I think
Yeah,
that's a great question.
I always- Ways on there.
I think it's a judgment call.
Yeah.
And I would base that, I would say probably a year is reasonable if I'm giving them a big chunk of steroids. If they're on 13 a day or higher, they probably should be on that as long as they're on 13 a day or higher. And that's my note to my gentleman right now with, who's on prednisone, got him get his bone density, it's normal. He's hesitant to use anything else. So that's our discussion for our next visit is, do you want to start on prophylactic or do we try to taper? I'm sure he's going to say, I don't want to taper. We tried a biologic. He's like, it didn't make me feel better like prednisone. So it's a negotiation, but I do my best, but how much of it is, a patient decision when I can't say your bone density is abnormal, that's a tough one. So, but they should be. Do I have some that aren't because I know it's an argument I don't want to have? Sure. And like I said, it's very easy with risk. If they have an osteoporotic fracture, a history of it, their bone density is abnormal, that's very easy. But when we're in this in between and we know there's significant risk, it's tough to justify that risk. Or heaven forbid, I had one patient similarly, had, a sonk fracture, a spontaneous osteonecrosis of the knee, terrible kidney function, can't get through, the VA to navigate to a separate therapy. Those can be some difficult cases. So talk about diabetes, since we're talking about the sugars now and steroids and some musculoskeletal complications. The diabetic chiroarthropathy, also known as the diabetic hand syndrome, Charcot joint, and diffuse idiopathic skeletal hyperostosis. So anybody here familiar with DISH? Seen DISH before? Okay. Runs with a spoon. It's too easy. I got jokes all day. So diabetic chiroarthropathy, really, difficulty to flex or extend the fingers, spontaneous extension of the fingers. We'll look at the prayer sign here on a separate slide, but cannot get the fingers flat. And multiple reasons for that. Stiffness and swelling the fingers often be painful to them. They'll have a waxy feeling to the skin on the back of the hand. And then other associated hand conditions. So we did have some with the VA with the whole triad. They had the diabetic chiroarthropathy, or quintet, I guess, or four, bilateral carpal tunnel syndrome. They can have the Dupuytren's contracture of the hand, the flexor tenosynovitis or trigger finger as well. So this gentleman had all four. So, and poorly controlled diabetes. So what do we think causes the issues with the hand? Collagen is more difficult for the body with diabetes to replenish collagen. The duration of diabetes, the longer they have it, diabetic microangiopathy, and then oncotic pressure, which, the best example of this I had was I very rarely read the JAMA and New England Journal articles about physicians seem kind of complaining a lot. So, but this one was very good, talking about the oncotic pressures of glucose. And she said the children called her and they said one of the chickens is sick. And she saw, I'll get to him when I get home. And she came home and had an omphaseal. And she said, I know what to do. I'm like, that's impressive. I don't know what to do with an omphaseal. But she said she had done bowel surgery before and scrubbed. But you put warm water and sugar on the intestine, it shrinks it because of the oncotic pressure, and they're able to put it back in inside an individual and then suture it up, which is what she did with the chick. So it's pretty neat. But I think that, especially for trainees, highlights some of the oncotic pressure, although glucose is not the most oncotic, forming, agent, albumin and other things much better. But where sugar goes, water goes. And I think that helps emphasize why we see these complications, especially for learners, understanding some of the pathophysiology along with the collagen and microvascular disease. So here's really the diabetic prayer sign. So And then here we're seeing, early Dupuytren's contracture, also known as the papal sign. So the history behind this for any Catholics in the crowd, St. Peter, the first pope, had Dupuytren's contracture. So when he did mass, this is a sign that's carried through generations. So you still see priests do it, even though they don't have Dupuytren's. So free history lesson. And then flexor tenus and vitus or trigger finger, which are locked. So we do injections for these. So does, the hand surgeon. So we're happy to do this for your patients as well. A lot of the benefit for the injections we do, although we give a small amount of steroid, is actually a needle tenotomy of the pulley system, which helps the body heal itself. So split. No, I think it's just the elevated glucose. So you're seeing a lot of things, not only the collagen and the microvascular disease. I think a big component, especially with the swelling in the hands, is really some oncotic pressure from, the hyperglycemia. Why that affects the small vessels more, that's a great question. I don't have an answer to. But I mean, increased risk of heart disease and other things, I think related to the sugar and oncotic pressure, although lower than albumin. So.
Related to glycemic control or?
I think duration. So if it's been going on a while, I think that changes the collagen and the microvasculature over time. Most of the folks that we see, with diabetic hand complications, typically poorly controlled diabetes. And it doesn't matter type 1, type 2. Hemoglobin A1C is usually markedly elevated. So that was a picture of carpal tunnel release on the last one, so I didn't explain that one. So the new term for Charcot joint is neuroosteoarthropathy, which I think is good. So if you like new terms and terminology, that's the new term. So see Dr. Mock smiling, so he likes the new terminology. Incidence, in general diabetic population, I think similar to what we're talking about, poorly controlled diabetes, particularly high risk, and then with peripheral neuropathy already, you're going to see more complications. Early signs, and I missed a question on my boards on this. It was numbness and tingling to the foot and some warmth, redness, and pain and swelling. I was like, oh, this is diabetic neuropathy. No, they wanted early Charcot neuroosteoarthropathy as the answer. So with the warmth, swelling, and other symptoms that suggest that there's early Charcot joint. Late symptoms, osteopenia is usually an early finding. And I think this came up on my boards as well, is looking at the bone density, and early loss of bone density is suggestive of Charcot joint, as well as reflex sympathetic dystrophy. Then you get fragmentation, coalescence of the bone fragments, reconstruction, remodeling, and then resorption of the metatarpal heads. I've never seen this, but I put a picture in for edification in case it comes up on boards as a lick candy appearance. So here's kind of Charcot joint, or, I kind of refer to it as mush foot. Everything is mushed together. There's coalescence and fractures. And what's that? Bag of bones. There you go. So, which is an unfortunate outcome. And, I've never had someone excited to have an amputation of their leg, but I had someone, with poorly controlled gout, wound up with, related to alcoholism, wound up with a peripheral neuropathy, and quit drinking, improved his life, got his gout under control. He called me up. We did a telehealth visit during COVID. He's like, the leg is off. It's gone. And it was, so fractured and broken. He had chronic staph infections and other problems. And he was happy as could be to get an amputation, and did great, resolving the other stuff, which was awesome. And here's the licked candy appearance. So you can see really resorption of the bone, completely gone, like a licked candy stick is how they describe it. But I've never seen this, so I don't want to see it. So do a great job stamping out diabetes and getting glycemic control well controlled, so I don't have to see this in my clinic. Yes.
How to differentiate, and that's two things.
It is. We still see some folks with reflex sympathetic dystrophy. Mostly, I would say, I have seen some downtown. Mostly the VA post-traumatic injuries. So an injury usually stimulates that, whether it's a bad ankle sprain, gunshot wound, surgery like a fasciotomy, and they get a sympathetic system that does not turn off. But how do we differentiate it? I would say the big thing is numbness and tingling would be the big thing. And you can see similarly just withering of the limb, because of reflex sympathetic dystrophy. Yeah. But, you know,
MRI.
yeah, I mean, all good questions, but yeah, early, you want to look for osteoporosis with both. You'll see that with sympathetic activation. Um, I was going to say something else about RSD, but disappeared. If I remember, I'll let you know. Good question. So DISH really, we'll have some pictures of DISH, but at least three consecutive levels of flowing ossifications, generally referred to as candle wax drippings, but large chunky osteophytes. In my world, we see these all the time, concern for spondyloarthritis, but if the sacroiliac joints are spared, usually something different. We can see a similar appearance with psoriatic arthritis that will have larger, what's called jug handle osteophytes, which are on the lateral aspect of the spine. Typically, DISH is more on the anterior aspect of the cervical, thoracic, and lumbar spine, but no SI joint involvement. Usually, it's a large percentage of population, so up to 12% of the population can have DISH. Usually individuals age 50 or older with a male predominance. As we age, that closes the gap between males and females. Don't use ageism techniques, but they did mention it as senile ankylosing hyperostosis. And then there is, a common shared HLA B8, which is seen with autoimmune disease, diabetes, and also DISH. And then other risk factors, kind of metabolic syndrome patients, as well as gout, increased risk. Treatment, really activity modification. So, they're limited in their mobility, NSAIDs, physical therapy. There's some non-statistically good evidence with TNF inhibitors like we use for ankylosing spondylitis and spondyloarthritis. Cohort was 8. We'll talk about that. They mentioned bisphosphonates for prophylaxis, but that doesn't really come into play. Really, the data for bisphosphonates is that they have a fracture. And then sometimes for severe complications, restrictive lung disease or other things we can see with this may require surgery. The big thing that comes up on my boards and may come up on your boards as well is someone with either ankylosing spondylitis or spondyloarthritis, DISH. They have a minor injury or motor vehicle crash and severe pain. Plain X-rays have been obtained. So anybody in the crowd want to answer what imaging study or what should be done next? So they still have pain, had a motor vehicle crash. What's the preferred imaging study? CT scan. CT scan. So that's always going to be an answer. MRI is not as sensitive and specific. So CT scan if you have someone like this that has trauma. So here we see the DISH. Let's see if I can get the pointer up and going. But here you see the large flowing osteophytes on the anterior cervical spine with at least 3 contiguous segments. So, and very chunky osteophytes there. Similarly, in the lumbar spine, you're seeing large flowing osteophytes. And a big thing to look at is preserved disc height. So the disc space in between is all normal. You can have some what's called crab claw spurs with degenerative disc disease. It's the body's natural mechanism for healing. So this is the study I put it up just for reference of TNF inhibitors, seem to provide some benefit. This is a long-term study, but, only a few patients have 8 and 1 dropped out because of infection. So perhaps some potential risk for, benefit for TNF inhibitors and some risk with infection similar to other inflammatory conditions. All right, you guys ready to have some fun? If you haven't having fun yet. Okay, got some good ones. Some hot cases. So thyroid acropathy, anybody seen this? Okay, seen it? Awesome. So really, they say pathogenesis unknown, maybe similar to pretibial mixed edema. The thyroid receptor antibodies themselves bind to the TSH receptors of fibroblasts and then induce kind of an inflammatory response. To me, it looks very similar to systemic sclerosis with how it works, which we know is a fibroblastic process. So, and then there's cell proliferation of inflammatory cells as well as glycosamine glycan deposition. So really, here's the thyroid acropathy. So you can see the large swollen fingers here, almost like a dactylitis. Now we see that with earlier presentations in systemic sclerosis. We call it sclerodactyly, where the puffy hands and then it eventually kind of withers away like reflex sympathetic dystrophy, and then you lose bone, which is really what we're seeing here. You see almost total resorption of the DIP joint here, large puffy sausage fingers. So probably similar process related to fibroblasts. I've never seen a case. So. Waiting. Hopefully not. Hopefully I don't see it. So posthumous gout. So Particularly in postmenopausal females, the risk for gout actually equals a male, but the joint distribution is quite different. So they'll often have a polyarticular flare at baseline, and it usually affects the DIP joints of the hands. So the reason why it does that is generally the females in postmenopausal may have osteoarthritis, so the joint's already damaged with poor blood flow. And cooler, we know that the uric acid precipitates at a cooler temperature. And then often they may have some mild renal insufficiency on a thiazide diuretic, so we start stacking poker chip risk for gout. I like animations, so people don't like it for presentations, but I love animations. So here you can see DIP quite swollen and red, concern for infection, but most likely gout. You can see some of the tophus here underneath if you look really closely with the yellowing there. So that's gout. But different presentation in females compared to podagra, which we usually see with males. All right, so I have seen spade fingers. Anybody seen acromegaly, x-rays, hands? Yeah. So really the terminal tuft starts to spread, and we'll take a look at that. You get overgrowth of periarticular bone, particularly at the interphalangeal joints, and then related to the insulin-like growth factor, which affects all the cells that we see with other osteoarthritis as well as inflammatory processes, the osteoclasts, chondrocytes, and fibroblasts. So again, kind of large puffy fingers. And then the big thing we're seeing here is changes to the DIP and PIP joints and the appearance of a DIP joint that looks like a spade right at the end of those joints. So rickets, hyperparathyroidism, renal osteodystrophy can all cause rubber jersey spine. Anybody seen this? Excellent. So really kind of osteosclerosis at the superior and inferior end plates of the vertebrae. So here you can see the sclerosis on the top and bottom compared to a rugby jersey for anybody else who's played rugby. So chondrocalcinosis, a lot on chondrocalcinosis. So, we see a lot of CPBD in our clinic. It's not recommended to do a workup if patients are under the age of 50, but generally I look for the top two conditions, which is, underlying hyperparathyroidism, which is associated, and then hemochromatosis. So those are two things I look for over the age of 50. So causes are listed in, prevalence order. So hyperparathyroidism, really the highest risk, followed by hemochromatosis. For those of you who are just checking ferritins and forget how to do the transferritin iron saturation percentage, which I do all the time, I have to look up the calculator. Really, it's the elevated transferritin percentage that defines hemochromatosis and justifies genetic testing. Next on the list would be familial hypocalciuric hypocalcemia as a risk factor. Hypomagnesemia is also a risk. Hypophosphatasia with elevated alkaline phosphatase, lower on the risk protocol. And then, historically, I was trained in fellowship. Hypothyroidism is associated, which has been proven to be incorrect. It's actually, if they have chondrocalcinosis and you replace thyroid hormone, that can induce a flare of CPBD arthritis or pseudogout if it's monoarticular. I don't know the pathophysiology, though, if anybody's looking for that. Sorry. So here we see, I put arrows on this one, so we don't have to use the pointer. We can see the deposition at the triangular fibrocartilage in the wrist. Oftentimes the biggest cause for wrist inflammation post-hospitalization, the wrist is a grab point. So if there's chondrocalcinosis there, when they're being moved in beds, maybe getting some medications to sedate them, that'll break off calcium. And we get a lot of consults for monoarticular arthritis in the wrist after hospitalization from CPBD. You can also see it at several areas of the MCPs, which are the most common areas, kind of here in the fifth, and then also here in the first as well. And then just for your edification, we see a lot of chondrocalcinosis in the knee. That doesn't necessarily mean that they have CPBD arthritis. In 50% of patients over the age of 50, they'll have evidence of chondrocalcinosis in the knees on plain film imaging. So we get that a lot for knee osteoarthritis and other reasons. And that lines the meniscus itself. All right, some good cases I've seen recently. This is a patient we share with osteopetrosis, and similar to the rugger jersey spine with osteopetrosis, they refer to it as sandwich spine. So you can see the sclerosis above and below. And a referral was for concern for ankylosing spondylitis, which it does not look anything like that, or dish, but so we also had another case that Dr. June and I shared. So normal phosphatemic tumoral calcinosis. Anybody seen a case of that? Me neither. So actually, Dr. June didn't see it. This was inpatient. So a gentleman with poorly controlled renal failure, skipped dialysis, and then developed these massive areas of calcification in the neck that looked like a tumor. So it can be liquefacted at multiple components of different calcium, basic calcium, CBBD. And here you can see on the lateral cervical spine, massive amount. So they're of course concerned for cancer and other things. Did a biopsy, and of course asked me if colchicine would help, and I said no. And this can get worse with surgical debulking too. So it's a pretty difficult scenario to be in. All right, so I had 2 cases a month of osteogenesis imperfecta, which is pretty rare for me. I sent them to the metabolic bone clinic. But there's other things in our differential diagnosis. So anybody know of a rare disease that we could see with blue sclera that may be more concerning than osteogenesis imperfecta? Okay, I found one. So we were doing kind of aortitis, but the Loeys-Dietz syndrome. So if you see somebody with blue sclera and they have, a couple key features of this disease, particularly in childhood, they'll have hypertelorism, so the eyes will deviate out. They can have a bifid uvula, also clubfoot, and they can have arachnodactyly too, so some overlap with Marfan's appearance. And then the most important thing in identifying these patients are very high risk for aortic rupture and aneurysm. So because of the collagen disorders, something to keep in your differential diagnosis. Not all blue sclera is osteogenesis imperfecta. So that was new to me. So this one I've been looking for my whole career since I got quizzed by my wizened internist when I was a 3rd-year medical student. He said, Dave, what do you think about someone with a foreshortened 4th and 5th ray on their hand? I was like, oh, that's pseudo hyperparathyroidism, sir. Never seen it. And we had someone walking in the clinic. So, but really mutations in the GNAS gene, which is the signaling pathway for parathyroid hormone, usually respond normally to PTH, and then usually genetic inheritance is from the father. Symptoms in youth may include short stature, round face, the foreshortened digits that we talked about, soft tissue calcifications, and then learning disability in some individuals. So when I initially saw this veteran, the referral was for perihepatic and subcutaneous calcifications. And we did evaluation for any parasitic or other causes. In questioning him, he had a severe IED exposure where he was not in the immediate zone with shrapnel, but in the air blast zone, was blasted back, I think, 100 yards, knocked unconscious, medevaced out to Germany in launch stool. And so when we got that history, I said, oh, this is all, post-traumatic calcification. And then his son started to develop similar calcifications. So here you can see some in the hamstring area on both images. But his son started to develop extruding calcium from his ankle and his umbilicus that formed sharp needles that came out of the skin, which prompted evaluation, got genetic testing, and both he and his son were positive for the GNAS1 mutation. So, and then hopefully the son may be going to Indianapolis to get some further pediatric endocrinology care for us. So I have our code for those online today. My cell, in case anybody has questions. If you can't find me, I'm sorry. I always have my cell on me, except for right now, it's in my backpack. It's lecture. But please call me if you have questions, concerns, overlap disease in particular. I'm happy to answer them for you. And here's my daughter and wife at the Yum Center. They got to play basketball on the court, which was awesome. So they're super excited about that, which is great. And then let me see here. I need the taskbar. See if any questions. Show taskbar. Let's see. I don't know why it's not showing up.
Oh.
Any questions from the group? No, I kept you 2 minutes over, so yeah. Yes. Always fatigue. Yes. Everybody wants to answer for fatigue. In fact, we even have different types now. So we call it fatigue with lupus, type 2 lupus. So lupus that we can't treat, but common symptoms like migraines. It's one of my long-standing patients that I've been here, but I sent her a long, informative talk on managing fatigue with lupus other than steroids. She said, "What can I try?" She had some depressive symptoms, so we tried Wellbutrin, which can be energizing. Still having depressive symptoms, didn't change her energy level, but the fatigue is difficult. And for lupus in general, as a common complaint, which we just don't have an answer to. We can't suppress the immune system more, can't, but definitely overlap. And of course, everybody wants their thyroid tested a million times, make sure it's not the thyroid. I know, right? You can laugh. It's funny because it's my thyroid. I swear it's my thyroid. No, you're fine. Your TSH is fine. Your free T4 is normal. Yeah.
But it's adrenal fatigue.
Always, right? Yes. But yeah, that's an overlap with everything, which is difficult. So, but I mean, it can be a serious manifestation of autoimmune liver disease, Sjogren's, other things. Not that treating those diseases are going to increase and decrease the fatigue, but we see it.
Well, the is T-course, but they will say that if it is there, they get more.
Yeah, it's energizing. And I had someone the other day with sarcoidosis. Pulmonologists community hesitant to diagnose it, even though it had pulmonary nodules, dactylitis, which we see with sarcoidosis, a skin rash, which responded to hydroxychloroquine, elevated ACE level. I mean, everything's there. And he's like, man, started steroids. I felt great, clamped up, right? It's great until we run into problems, And it's a love-hate relationship with steroids. And then people do feel better. I get it. And ironically, I've had 2 healthcare providers I've taken care of become addicted to steroids. If 20 makes them feel good, 40 is better. If 40 makes them feel good, 80 is better. If 80 makes them feel good, 160 is better. All the way up to 300. I watched, one have a, severe addiction, kept asking me for refills. And this is a colleague, and wound up with a fungal infection in his eye because he was getting eye injections for, macular degeneration. Another was, a nurse I, worked with and, literally in front of my eyes, gained 100 pounds in several months and was asking all the other fellows and colleagues for steroids and was taking 300 a day. And they're addicted. I mean, people feel good on steroids. I get it. But then we have complications, which is tough. But ripping that Band-Aid off, I think now, really my practice, I used to start people on methotrexate for RA, taper it down slowly, and then I can't get past 10, I feel great. Now I just don't even do it. Like if you're having a bad weekend, take 5, here's 30 for the next 6 months. I'm not doing the daily and waiting for DMARD to work. I found that that's much easier on me, patient, and I don't get patients who cannot get off of steroids. The trouble is someone who's been given steroids for a while, once you get them, they're never coming off. I try, unless they have a complication. It's like opioids. And I mean, I think there's a lot of good that steroids do for acute gout flares and things like that, but then they won't come off. Tough. Thanks. Yeah, I don't see any questions in the group, so that's great.